Good evening, viewers of Temple Africa TV, the only Pan-African broadcasting outlet that promotes people, associations, institutions, and companies working to help revitalize Africa as a united, prosperous, powerful, and sovereign continent. Welcome to our show, What's Up, Africa? Que fait l'Afrique? I'm Professor Desiree Balubi, a Temple Africa TV volunteer host from Norfolk State University, the best HBCU on the East Coast of America. Our topic today is healthcare access and life-saving programs in Africa. Please join me today in welcoming a very special guest, a medical doctor and published author, Dr. Farmer Chukwudi Nwanko. Pediatrician and family physician, Dr. Nwanko is comfortable caring for newborns as well as centenarians. He has practiced medicine in different types of healthcare settings. He also specializes in telemedicine and home-based care. He has treated patients by telemedicine on all the continents. So that means all the continents except Antarctica. Apart from Antarctica, Dr. Nwanko, as you claim, you have practiced telemedicine on all the continents. So I will be remiss if I don't ask you whether or not you do this for patients in Africa as well while you're here in the United States. What do you say?
I have consulted and treated on patients in Africa as well as in the United States. Right now, I just got off a phone call with a patient in Nigeria. And once this program is over, I will complete my management. So I can do it, and I don't need a video. Most of the time, it's just through texting and phone calls, and I will get the history. Sometimes I use images, since telecommunications is so poor in Africa. Other continents are talking about 5G, but I think we're still operating at 1G, bandaged as 4G LTE. So the connection is not very secure. It's more like narrowband. So most of the times we make do with texting and imaging.
Are you kidding me? 1G, or are you just exaggerating? You're kidding.
Well, the point is that you may have a 5G tower that's supposed to carry 10 messages or 10 conversations at a time, and there are 200 people trying to access it. That's where you have the problems. So at heavy periods, your text messages could arrive 2 days later. That's been my experience.
Yeah. So I believe we will discuss technology at another time with people who actually work with technology, because that must be resolved. Telemedicine is so important. You can be here in the United States and actually, just talk to patients and find out what's wrong with them and propose a cure for them. So that's wonderful. But now, before we go any further in this show, allow me to tell our viewers a little more about your background. After his medical education at the University of Nigeria, Dr. Nwanko underwent residency training in pediatrics at Wayne State University in Detroit, Michigan, and family medicine training at the University of Tennessee in Memphis, Tennessee. Under his belt, Dr. Nwanko also has postgraduate degrees in public health, toxicology, and business administration, and all of that from the University of Michigan. That's wonderful background. Earnestly speaking, Dr. Nwanko, you have so much to offer, and there are so many questions I believe you can answer so comfortably. So let me go back to telemedicine, if I may. What does this fairly new practice mean or entails? And what good news may that bring to fellow Africans at home?
Well, with telemedicine, you can access the best care anywhere in the world. And there are even further advances whereby doctors could operate on somebody 10,000 miles away through robotic technology. So telemedicine is really something that can improve access to underserved areas of the world if we have the necessary telecommunications equipment in place. So especially with the current pandemic, telemedicine has become one of the ways to see patients without endangering your own health. And some of the insurance companies, or almost all of them, have now started reimbursing telemedicine at the same rate as face-to-face medicine, if I will put it that way, as office practice. But we hope the practice will continue after the pandemic because it's a way of extending care to a larger population, as well as a way of minimizing the risk of transmission of very contagious diseases, such as COVID-19.
So I'm hearing you well. You're saying that telemedicine has a lot of advantages, and technology is the backbone of it. Is that correct?
Yes, that's the backbone of it, technology, which means, cellular, you can do it cellular through cell towers, or if you have a fiber optic connection to the internet. Now we're talking about satellite-based internet communications. There was the balloon-based internet communications, but there's a dearth of reliable internet services in Nigeria, in Ghana, in Kenya, all over Africa. And once we start thinking of telecommunications as health infrastructure, we're not going to get anywhere because it's part of health infrastructure. Nowadays, you can have an X-ray done in Boston, interpreted by a doctor in India. It's happening. Doctors who have trained in radiology in America, they'll go back to India. Because of the time difference, somebody comes into the emergency room at 2 a.m., the radiologist is sleeping at home with the family, is sent to a company in India that interprets it so the emergency physician can act more expeditiously without endangering the patient's life.
That's interesting. As you know, you're talking to the entire continent and also African diaspora. So if you were to just look in the camera and say something to African government, what would that be in terms of advice, telemedicine, and what you can do from the USA, what any licensed medical doctor can do from India, from France, wherever they may be, in favor of African patients on the continent of Africa?
I think the problem of access in Africa is political. There is an intersection of health and politics. What I have observed is that Africans, especially the leaders and the politicians, they don't care about their own health. So why would they care about the health of their citizens? Tell me, if a president has a heart attack in Kinshasa, there may be no hospital to take care of that president. Same in Abuja, same in Accra, same in Kigali. Okay, African leaders travel overseas for treatment. So they don't pay attention to the health infrastructure in their continent. If you have a heart attack and you are not seen within 1 hour, which is the golden hour, there's damage. There's going to be a lot of damage to your heart cells, Within 80 to 90 minutes, the cells will start dying. And in 6 hours, the death could be irreversible. Same with a stroke. Within 5 minutes, the brain cells will start dying. And tell me, you have all these jets. No jets will fly you from Nairobi to London in 1 hour. And not only do they not think about their own health, even though the health of the family, because I believe if every African country has a center of excellence, or if it would become law that no leader should seek treatment outside their shores, if need be, they don't have the required expertise, you can have an expert come in to assist. For instance, when Boris Yeltsin had a heart problem, he was operated upon in Russia by Dr. Renat Achurin, but Dr. Michael Debicki was observing. He had trained Dr. Achurin at Houston. So we don't have the facilities. Talking about telemedicine, as if somebody wants to operate on somebody in Nigeria, assist in the operation, and then during the operation, there's the power supply goes out. We don't even have reliable power, which is all these are part of healthcare. You know, you're talking about a continent blessed with sunlight, water, wind. What else? We have uranium, we have coal, but we're still talking about load shedding all over the continent. Some of the countries that didn't have that problems are now experiencing it. South Africa has the problem now, Ghana has it. These were countries where you never had problems. So there's a lot of problems in Africa, and it has to do with infrastructure, which is part of health. And if I may go further, the United Nations describes health as a state of complete physical, mental, and social well-being, and not the absence of disease or infirmity. I would even say that description is wrong. It should be a balance of physical, mental, and social well-being, because you cannot be free of anything. But Africans understood the problems better than the WHO. There was a study done by the African sub-region of the WHO in 2012, and Africans added emotional, spiritual, and economic. So a lot of deaths in Africa are due to malnutrition. If you contract a disease and you are malnourished, you can't fight that disease. First of all, if you're not malnourished, you may not even get the disease, because all you are fighting, mechanism is in top shape. You know, your white cells and all of your skin, all of them are barriers. But when you're not eating well, these barriers are very fragile, and they won't prevent contagions from getting into your system. So the Africans understand this problem. If you don't have a job, you can never be in a state of good health. You'll be worrying about where the next meal is going to come from. Okay, it's going to affect your brain. If you are prone to psychiatric illness, it will start manifesting. So first thing first, African leaders care for your health. Okay, have the facilities. There was an example of a highly trained orthopedic surgeon, Dr. Enyo Kereke, who went to Enugu, Nigeria, and was giving lectures to students, had a heart attack, and died. Oh. I'm not saying that all heart attacks survive. We don't even know how to do CPR in Nigeria, in Ghana, in Kenya. You know, it's something that if you die, they will just lift you and put you in the vehicle and start going to the hospital.
Aren't you overgeneralizing? How can you say people can't not do CPR in Nigeria, in Ghana? Are you not exaggerating?
Well, I'm not exaggerating. I've seen it on videos. There was one lady, there was a video on WhatsApp that was dancing and suddenly collapsed. Everybody was standing around. I've seen it. It's not that, what I mean is like here, even a high school student knows how to do CPR. That's what I'm talking about. If you
But
happen to have somebody,
Dr. Nwoko, not everything we see on WhatsApp can be taken seriously. We have to take it with a grain of salt. And there's a lot of, pardon the French, garbage on WhatsApp, fake news as they call it these days. Are you taking WhatsApp seriously to, taking it for, gospel truth? Or
I
you
do
talk
not.
to people
I do
who
not.
are on the ground?
In fact, they call me a refuter on WhatsApp. I've never posted any fake news and I debunk them. I label them as crap. And some people have actually started using that term, crap. Okay. But there are some real things. Let me give you a personal experience also. I was once traveling in Nigeria. This young kid was knocked down by a vehicle right in front of me. I got out of my vehicle. Before I could get there, a helper, in quote unquote, picked up this girl and broke the neck. Then I started telling folks around how to care for somebody. You don't move them. Okay, when you want to move them, make sure that align the neck and everything and leave them carefully onto a firm surface. Then the next time I went, one relative told me he witnessed an accident and he did not leave the person and that person survived. You know what I'm saying? There's some exaggeration in it. But Prof, what I'm telling you about CPR is, I don't think 1% of the population know how to do CPR. It is not, and not everything on WhatsApp is fake too, because I do post on WhatsApp. When you read WhatsApp, you have to know who the real authorities are. Okay, you have to know the source of the information. I've actually written on how to discern fake news from real news. The first thing to do if somebody says this happened, just put it on your browser, because that could be a fake news that I'm dead. Okay, if you put it on browser, it says no, I'm alive. That's it. But people are so gullible, and the level of education doesn't even address it. People are just so gullible. If they will have people they relate to, I do get posts sent to me personally to verify. But some people are too big and they don't want to make the efforts to vet whatever they post. So I'm not taking WhatsApp at gospel truth. Let me just put it that way.
Okay. Oh, thank you. But the good news is that something positive is being done all over Africa. I know you mentioned technology, you mentioned energy. Those two things are key to actually solving some of the problem. What can you do without energy in any country that wants to be developed? You want to grow anything, develop the medicine, the economy. You need energy. You need technology these days. And talking about telemedicine, based on what you've said, I can also say that maybe people like you and people on the ground need to focus on medical education as well. They need to take it very seriously. Those are the basics. If you're talking about people not knowing how to do CPR, isn't that basic? So people need to focus. I'm not giving any lesson, but gathering from what you're saying, I think it is important. And the good news is that we all got to be optimistic and know that, after all, most, if not all, of the solutions are in Africa. And thank you indeed. And I was wondering if you knew something about AMREF Health Africa, and that's an example of good things happening in Africa. And MREF is a non-governmental organization. Let me read this to you, and you can tell me what you think of their mission and whether you know of any similar organization that may be based here in the US, anywhere else, or on the ground in Africa. And here we go. Amref Health Africa was officially founded in 1957. So that's not something new. That's a long time ago. And they were founded to deliver mobile health services and to provide mission hospitals with surgical support. A medical radio network was developed to coordinate the service and provide communication. And in the early 60s, ground-based mobile medical services were added, along with flight clinics for the underserved and remote areas in the Kajiado and Narok district. Today, they work across Kenya with a diverse range of communities from urban slums in Nairobi, remote rural areas in the northeast and south, to even the lake regions in the west and coastal region in the east. With an annual average budget of 35 million US dollars, they have carved out community health, and I'm just paraphrasing or quoting them, community health system, strengthening as a distinct area of expertise, and use this advantage to forge collaborations and partnerships across the country. In line with the Amref Health Africa in Kenya's strategic plan, and they have that strategic plan for running from 2018 through 2022. Their solutions are geared towards supporting a developed system of government, addressing the needs of vulnerable population, especially women, children, and youth, and addressing the burden of infectious diseases, non-communicable diseases, and maternal mortality. A strategy they claim is aligned to the constitutions of Kenya and the country's Vision 2030. Okay. So, Dr. Nwankwo, you are also a published author. Okay, we'll come back to that. But just speak to what I just read to you, and then we'll come to your other talents that you have.
Oh, well, that's a commendable effort. But sometimes you have a competition for resources. And that competition, for example, in an area where there is no water supply, where there is guinea worm infestation, no potable water, will establishing a small clinic help that community more than having clean water supply? In the 1500s to the 1800s, life expectancy in Europe was 30 to 40 years old. Now, it is 70s to 80s. It has doubled. And most of these advances were not the result of having doctors or clinics. It was due to environmental sanitation, preventive medicine like vaccines, communications, improved standard of living accounts for a lot of this modern health. So when the African says that the economic well-being is part of health, I agree totally. So for instance, maternal mortality is still very high in Africa. I don't know how we can solve that through telemedicine or mobile medicine. Telemedicine can identify the problem, but there must be a facility that is accessible where the pregnant woman can undergo a safe cesarean section. Even in communities or in countries that claim to have free healthcare, the perception of services you get in the government-owned facilities is that of indifference by staff. Sometimes you are made to wait for hours and you may die waiting, or if you don't have the money, nobody will see you. So why I commend AMREF for what they're doing. I tried to Google it. I didn't see, I didn't really get, but what they're doing is commendable. But it has to be in conjunction with established facilities too. And healthcare doesn't mean medicine alone or doctors. It means having a job, having a roof, having water, having communications. And when all these work in tandem, the health of the African will be improved.
That's fabulous. And I hope people will actually listen to what you're saying to understand that healthcare is not just medicine. It's the environment, it is job, it's employment, and everything else. And education, we should also say, right? Because we're talking about CPR, so education. So, let's go talk about technology, talk about energy, talk about, the environment, and all the rest of it. It's just a bundle. It's not just, in health, in isolation, detached from everything else. So that makes sense to me. So I was saying that you are also a published author, Dr. Nwankwo, a poet, polemicist, logician, and philosopher. And this actually reminds me of the era of the Black erudite in ancient Egypt and ancient Timbuktu in Mali. Do you plan on writing books for health education or partnering with either US-based organization to build an ultra-modern and well-equipped hospital in Nigeria, Benin, or anywhere in Africa, so that our people, especially the least fortunate ones, don't die simply, as you said, don't die just for trivial. Is there anything called trivial disease? But simply because they cannot afford the cost of emergency medical transfer to Great Britain or France.
Actually, I wrote a book, The Human Automobile, where I used the automobile to teach health education. And what that book is all about is like there are similarities between the automobile and the human being. And some folks will kill you if you scratch their automobile with a fingernail. But then they will see a lump growing on their butt, and they say, oh, it's nothing. The next time it's cancer. About building something, I have actually drawn up plans, full detailed plans and everything for a hospital in Nigeria. We have some problems with getting the land because the land we acquired, there's some dispute over the land. But I hope to break ground in the next year or so and have something. I don't have all the money. I hope I'll get some partners. But like I was saying about our leader, we need something that will now disseminate information on good practices to other facilities, to other providers that could serve as a center to publish materials on CPR, as a center where people can come and learn CPR, can come and learn advanced life trauma support, can come and learn advanced cardiac support. These are things, when you have somebody go to school, get advanced qualifications, and dies because of a simple ailment, that represents a great loss of society. We don't have too many of those. It will seem that I'm emphasizing curative care. Not really. Prevention is actually also, it's even higher on my list of priorities. But while we talk about the other aspects of it, is that you don't want to lose somebody who've put in all the resources. The whole village contributes money to train a physician. He goes overseas, comes back, and then has a simple food in his throat, and you don't know how to do a Heimlich maneuver to get out the food, and the person dies. That represents a great loss. If a doctor dies in Los Angeles, nobody cares. There are about 4,000 of them waiting to take that doctor's place. Okay. If a doctor dies in Kivu, who's highly trained, he may not be easily replaced. So I'm looking at those things, and like I said, I've drawn up plans to have something. If I don't do it, I've told my kids they have to do it, or a ghost will be hunting them. So, so I have plans to, and also, like I said, everything I've done so far, I don't charge for it. I've never taken any cover from anybody for telemedicine. Even when I go to Nigeria, I treat people free. But my people have this perception that when you don't charge them, it's substandard care. Wow. And also, 15 to 30% of Africans seek alternative care, because they believe that cardiac failure is a cause, or that I stepped on something, or somebody poisoned me, or is the witch. That's some of the problem. But when I want to treat somebody, my first injunction is, if you don't want to stick with me, please find something else. Too many cooks spoil the broth.
Yeah.
And a lot of them do. So that's another problem. Problem of wax, problem of expired medicines, problem of substances that are not medicines, packaged as medicines. So we do have a lot of problems, and it takes the political will to solve these problems. I was once in Nigeria, and there were more people lined up at the pharmacist than at the physician's office. And would you believe me, they pay more to the pharmacist than to the physician. So it has to be a reorientation.
Right.
And as doctors, we have to do our own parts too, because a lot of doctors don't practice real medicine. I don't know if it's lack of knowledge, or is a way to make quick bucks, or has it been ingrained in the culture?
I don't think so. I mean, that's no, it has nothing to do with the culture. But something is interesting. You keep referring to politics. Yes. I also believe that if we take politics out of a lot of things, we may get a lot of improvement, because not everything has to be related to politics. You're talking about political will in the sense that there is a policy for healthcare, for example. But I would hate to see people politicizing healthcare, for example. You see what I'm saying? This is about people's lives. So there shouldn't be any politics around that. I don't care which side you sit on the political spectrum, but this is health, human health. So without health, we don't exist, do we? And once we have the health, then we can talk about education, then we can talk about technology and energy and everything else. So people need to be actually very, very sensitive and be more serious about this thing. And you said if a doctor dies in Kivu, it will be very difficult to replace that doctor. Contrasted with the death of a doctor in Houston or maybe somewhere else around this place in the United States. And at the same time, that is true, because Africa, you see, is about 54 countries, and we have this issue, and yet when you take every single country, I know for Benin, for example, there are more doctors in France than there are in the entire country of Benin. And the case may be true for Nigeria too. Is there any concerted effort among fellow doctors in the diaspora, to reach out to the continent, to go back, not individual effort like yours. Yours is really, your effort is really commendable. And people thinking that it is cheap because you're not charging them, that's ridiculous. And that's easy to solve. But the bigger picture, where do you see that? you folks, the diaspora, African medical doctors partnering with even American or Chinese or British, what is that concerted effort that you're making, or any association, anything of that nature, to not just not even Africans alone, medical doctors abroad, without relying on Chinese or anybody else? You could do something, couldn't you?
I think you've raised. First of all, let me say something on the politics. Politics is not a bad word. Every living person is a politician. So when I hear that term, leave it to the politicians, it does not make sense. Okay, you elect the politicians. Okay, any married person is a politician. Any kid is a politician. Sometimes you have to use politics to navigate between both parents. What I mean by politics, take for instance the case of Turkey, Kemal Atatürk. One person, he secularized Turkey. Right now, we have another leader who's trying to go back to theocracy, something like that. That's what I'm talking about. There are single people that can, if somebody is a dictator and can control everything, they might as well dictate that we have healthcare. We have that. So sometimes the priorities are wrong, or they don't really care. That's what I mean by politics. I'm not talking about politicizing medicine or politicizing what. Okay, take the instance of China. China is a communist country that practices capitalism. how do you you see what I'm saying?
Yes.
And they take pride in lifting so many people out of poverty than in any other. That is politics. It was the politics. It was Deng that opened up China to the West. If not, they will still be eating rats and all that. But they have gone past that now because of politics. So politics is not a bad word. Okay. I hope we got that. Talking about cooperation between people in the diaspora.
Right.
Sometimes I laugh a lot when I see Africans overjoyed and ecstatic at an African excelling in the US. You know what I asked them?
No.
Do you see Americans jumping off rooftops because an American doctor is now excelling at the University of Benin?
No.
No. We should be happy when Africans excel in Africans.
Yeah.
And why does that not happen? It's a brain drain. Okay. You train highly, you go back, there's no facilities for you to practice. You may even be kidnapped or killed by terrorists or whatever. Okay. They don't have that infrastructure, and they don't care about the infrastructure that will enable these doctors. I remember when I was trained by doctors who trained overseas. We didn't have much, but everybody who went overseas came back and helped train. But nowadays, people who are in Africa want to leave. There is instability, there is economic upheaval, there's poverty, there is terror. So we don't have the right terrain. Some Nigerian doctors in America do go back under the auspices of AMPA, Association of Nigerian Physicians and Americans. You know, I'm part of it. Who put up workshops to train Nigerian doctors, do what you call what do you call it again? Health missions. Right. Even though I'm not. There are some types of health missions that I fully subscribe to. There are others that I think are just mere window dressing. If I remember right, the concept of health mission started in the Philippines, where doctors went to the Philippines to repair cleft palates and educated and trained Filipino doctors to start doing it. That is the type of health mission that we should be encouraging, where a transfer of knowledge and technology. The next time they'll come with some new clamps for fixing the palates. But going to health missions in one location today and going to another one, and there is no record of anything done. If you ask the doctor, what was the blood pressure of this Mr. Okagore you saw 2 years ago? They don't know. There's no follow-up. But I fully subscribe to the idea of a transfer of knowledge, just like Dr. Debicki went to Moscow to observe, because the heart operation on Boris Yeltsin, because Dr. Debicki was the first guy that did open heart surgery. Okay. And then he trained Dr. Achurin. So stuff like that, but he did not operate on him. Maybe, I don't even know if it was necessary for him to go, but maybe Dr. Achurin felt more confident. If I had my mentor as I'm operating on the president, that will help. So I really subscribe to your idea of transfer. But Prof, do you know that sometimes you may be going to transfer that stuff, somebody will want you to pay them before you do something. That's another problem.
Yeah.
Let's leave that now.
Yeah. Dr. Nwankwo, what you're saying reminds me of Alex Cabo's book titled Et si l'Afrique refusait le développement, which means what if Africa turned down the development that we're all fighting for. So that I didn't think that was still, real or relevant. I thought that belonged in the past. But I think we have some work to do, and it would take people like you, like me, and everybody actually to contribute something to changing the trend. And let's talk about what is current here, and like infectious diseases that we've been talking about. How is Africa, by the way, dealing with the COVID-19 pandemic and the acquisition of vaccines to protect our people? Do you have any information around that? Any information about how they're faring, how they're doing?
Well, Africa is doing well in terms of caseloads. Except for South Africa, that is being devastated by COVID. The other African countries are not having it as bad. There are so many theories for that. Maybe we have been infected by variants of COVID because of the level of environmental sanitation and everything else. So somehow our antibodies are preventing us from getting COVID. It's just hypothetical at this time. Some say, okay, maybe the malarial antibody has something to do with the COVID. The other thing also is Africa, a lot of Africa is in the tropics. It's always warm. The SARS-CoV-2 virus that causes COVID-19 won't survive for too long in the sun. Okay, but when it's cool, it's going to survive for longer periods of time. And when you are close by somebody who has it, it doesn't have to survive. It just jumps from you to the other person.
Right.
So, but there is COVID in Africa. First of all, we don't have health statistics, which is another area where we have a lot of problems. A lot of African countries do not know the population. It's just an estimate upon estimate. So we're not doing testing. So you may have it, but you're not manifesting. And before I forget, Africa is a young continent. 50% or more of Africans are under 20. And has been shown worldwide, COVID is not as devastating on the younger folks as on the older folks. But let's not get complacent. If you let this virus replicate unchecked in humans, it will make variants. What that means is that the DNA will suddenly, instead of being ACB, may be ABC. And that ABC, even though it's still the same A, B, and C, will be more transmissible, more devastating when you get it than the original ABC. So what the world is trying to do is to get everyone covered so that we don't have people acting as cauldrons that's incubating these dangerous organisms. By the time they get out, we won't be able to manage it. So Africa has done well, but we still need to get immunized, just like the rest of the world. And it's really sad that we don't have any vaccines made in Africa, because with the modern technology, it doesn't take much to sequence a gene. A machine can do it. You know, the SARS-CoV-2 virus was sequenced in January. And in February, they had vaccine candidates, which just means getting a piece of the viral nucleic acid, the RNA, string them together, you inject it into somebody, your body makes the spike protein, and since it's something foreign, your body will now make antibodies against it. So people have all sorts of conspiracy theories about this, but they tend to forget that the AIDS virus does the same thing, and nobody with AIDS has turned into a 5G antenna or have had their DNA or RNA or whatever changed. And Prof, we are not doing very well when it comes to infectious diseases. If you look at the causes of death in Africa vis-a-vis the rest of the world, would you believe that HIV that is curable is still on the list in Africa? Top 10. This is something where if you take the approved medications, is undetectable. Somebody who's taking the medications cannot give the HIV to somebody else, but it's still a problem in Africa because some people think, oh, it's not HIV, it's something else, or something. Oh, I don't want to take the medication. But it will take a lot of education, but we'll get there.
I personally have the feeling that some hidden entities are constantly plotting or lobbying against African indigenous medicine or pharmaceutical innovation that currently exists. Why can't we be free to consume what we produce? I understand the Republic of Madagascar, for example, used homegrown remedy for the COVID virus. And in my own country, Dr. Valentin Agon, a friend of mine, by the way, he made what he called Apiviril and was tested successfully as an effective medicine in the COVID-19 disease in Burkina Faso. So what is going on? And nothing can be made in Africa and being accepted, at least across Africa. And then the World Health Organization will say, oh no, or European countries will say, oh no, no. I don't know. What is going on, Dr. Nwankwo?
Prof, I'm a firm believer in indigenous medicine because a lot of the medications we use today come from plants.
There you go.
Aspirin, digoxin, taxominophene, a lot of them came from plants. And we have Westerners combing our forests and harvesting plants, fungi, and other animals that they now take to their lab and extract the active ingredients and come back to sell it to Africans. What I don't subscribe to is the idea that you formulate something and claim some curative properties without subjecting it to testing. The Madagascar, what do they call it again? COVID organic.
Right.
When it came out, I didn't buy that idea because there was no testing. And remember, after that, COVID-19 spread like wildfire in Madagascar. So, assuming there is something active in that stuff, which I think was based on artemisinin,
yeah,
same thing you use for treating malaria,
right?
And it must have also be linked to the use of chloroquine,
right,
for COVID, which did not pan out. So our problem is we have African governments. If we have something we think And I say government because we don't have too many billionaires. The few we have are too selfish to finance anything. But in the West, people steal from you when they're young. When they get old, they turn the money back over to you as philanthropy. But we don't do that. So I believe in organic, but there must be proper testing, double blind controlled trials. Okay?
Yeah.
If we do that, nobody will disparage any medicine from anywhere because we know that there are medicines as we speak now. People are finding medicine in squibs, finding medicine in all type of sea animal, all animals that they want to refine for use in humans. So nature is the original medicine.
There you go. So if nature is the original medicine and we have nature, we have plenty of it actually all over Africa. Okay. So the solution actually is with us. As someone said, here is the forest. It simply lies in your hand to turning into a dwelling place. So it lies in our hand to turn a forest into a dwelling place. You see, there's I'm a linguist, so people use words that I'm really sensitive to words. And some people even call our traditional healers, they call them witch doctors. That bothers me, and I hate their guts. God forgive me. Uh, but do you believe in collaboration between indigenous medicine and modern medicine? And what is your final statement or comment on in general? Say something about that, and I will ask you to
I think
final comment.
I believe in collaboration.
Very good.
Remember, Western medicine, but they encoded, they put it down in writing. That's how the rest of the world got it. Our problem is that it's a secret. Okay, some go to their graves with life-saving remedies. So that is the problem. Nobody wants to divulge. The Caucasian is proud to share knowledge to a lesser extent. But we try to hold on to what we have. Okay, if they can publish what remedies we have in Africa, I think some of them will be accepted worldwide. Okay, we had doctors before the Western trained doctor came to Africa. Not everybody died. We knew how to cure diarrhea and all those things, and they can be standardized. That's the difference also between the Western and the traditional medicine. In Western medicine, they know there's an active substance in something, but that same plant growing in the Congo rainforest is not the same when it grows in Ivory Coast because of the different composition of the soil and weather and all that. So you may have 2 grams per pound in Congo and 4 grams in Ivory Coast. So you can't tell somebody in Congo drink 2 gallons and the person in Ivory Coast drink 2 gallons. But if you isolate that active ingredient and now standardize it, that's Western medicine.
Wonderful. So you're hitting the nail on his head. Believe me, because we cannot talking about medicine. We can no longer depend on our on orality. Okay, we need to move from move. I mean, just keeping it secret because you don't want to share it with anybody. But at least if you want to keep it for your own family, the best way to do it is to keep it in writing, keep it in records of that, not necessarily audio, but also in text. Or why not digitize it? So that's why some of us are talking about advocating a change of paradigm. And it's writing in our own languages. Because you put this in writing in French, how many people can read French in Francophone countries? How many people can read English in Anglophone countries of Africa? But if it's written in Igbo, digitized, and I think that would spread like wildfire. And that's very important. That's something to think about. And I'll hopefully get someone in that area on the show to tell us how that can be done. If that something has already been done, so be it. Dr. Nwankwo, what is your final statement on this topic, healthcare access and life-saving programs in Africa? If we were to summarize what you...
My final statement is that access is limited. And when you access a health facility, you may not find the staff or the equipment, and that's wasted energy. What African nations should do is to draw up a plan whereby the territory is carved into health districts that's based on population and distances, and you can use technology to cover a wider area of your population. For instance, take the Zipline. Zipline is an American company that pioneered delivery of medications, vaccines, supplies, PPE by drone. In fact, it was pioneered in Ghana and Rwanda, and now they're trying it out on the East Coast of America. And what that can do is save a lot of lives. For instance, snake bites kill more people in Africa than elsewhere. People die from snake bites, which is treatable by an anti-venom. But you don't have anti-venom everywhere. It needs to be refrigerated. You can send anti-venom where it is needed by drone. The drone doesn't need to land. It goes there, it drops it by parachute. You can send COVID vaccines like they're doing in Ghana now by drone. You can sell personal protection equipment by drone where it's needed. You can send blood. Remember that maternal mortality is still very high in Africa.
Yeah.
So, and one major cause of maternal mortality is postnatal bleeding after birth. They may bleed so much that you need to transfuse blood. You need to get some medication like oxytocin and some other medications that you don't have at the local facility, but you may have trained some midwives in that locality on what to do. So I see an interplay of technology, political will, and infrastructure, which is also part of technology. If we have this in place, we can serve a lot more people, and not just saying you're spending this percentage of your GDP or GNP on healthcare, because we know that will not solve our problem. First of all, if you say they're spending 6%, it may be only 3% going to the into actual healthcare. Africans have to demand services from our leaders, okay, from the politicians. We have to say, if you think our universities are good, your children will go to university in Africa. I went to university in Africa, but I tell you, I can compete with anyone from anywhere in the world. I don't think we have those standards anymore. So we need to, if the leaders think highly of themselves and say, okay, let me do something for myself that I want done to every other person, even the least, what you call the least person, because I take every human being as the same. I treat everybody as the same. And that's the new paradigm. That's the new political orientation. Let's do something for ourselves, not depend on other people. So before I go, I was reading the other day that Oxfam has been in Congo for 50 years. I was surprised. It was surprising. We should not depend on anybody for aid. People cannot come into Africa, take our diamond, take the oil, take the cocoa, make a lot of money, and then give us pennies as aid. No, we can process the cocoa and send to overseas.
That's right.
I will end on that, Prof.
Okay. Thank you for contributing immensely to What's Up Africa, Que fait l'Afrique today. Temple Africa TV is proud of you, Dr. Nwankwo, and we look forward to inviting you back to share more success stories, not only with us, but also with the entire continent of Africa. Viewers and friends of Temple Africa TV, should you know of any talented person like Dr. Farmer Chukwudi Nwankwo, who is involved in innovative projects with the potential to transform lives in Africa, please share their contact with WhatsApp Africa, Kofel Afrique, via africtv@gmail.com, or simply dial 612-224-2020. This is also on WhatsApp. Humbled and privileged to host this weekly show. Again, I'm Prof. Desiree Balubi from Norfolk State University in Virginia, USA. Thank you for watching, and have a very pleasant and blessed night.
C'est encore Yves Kenao, c'est toujours Yves Kenao qui revient. Cette fois-ci, pour vous dire que Tempo Afrique TV vous offre plus de 4000 chaînes de télévision. Les chaînes européennes, les chaînes américaines, les chaînes asiatiques, les chaînes africaines. À un prix imbattable. À un prix imbattable. Tenez-vous bien. $185 pour 12 mois, inclus le box. Alors, où est-ce que vous pouvez trouver mieux que ça, si ce n'est pas sur Tempo Afrique TV? Mesdames, Messieurs, appelez seulement le 612 804 0295 et vous serez servi. Vous serez agréablement surpris de voir plus de 4000 chaînes de télévision rouler sur votre écran comme ça, et vous choisissez laquelle vous voulez. Alors mesdames, n'hésitez pas. N'hésitez surtout pas et ne vous faites pas compter. Prenez votre téléphone, prenez-le tout de suite et appelez le 612, le 804, le 02 95. Nous sommes là, ici à Tempo TV, pour rendre votre vie simple et agréable. Alors, saisissez l'occasion. Donc, $185 pour toute une année, pour 12 mois, inclus le box. Quoi de mieux que ça?